In this prompt, we are working with a patient and we see that this patient has had a heart attack or a myocardial infarction. With this myocardial infarction, they have also recently had bypass surgery. So before we even get into some of their medications and some of the effects we might see on cardiac function, some of the things we just may see in general with those medications, let's hit on these guys really fast. So myocardial infarction is a heart attack. And what we see with heart attacks, most commonly they're caused by things like coronary artery disease, where we get buildup of plaque, either soft atherosclerosis or hard atherosclerosis in our arteries, and we cannot get sufficient blood flow and therefore oxygen and nutrients to the heart. So nutrients to heart. Initially, this is called ischemia, when we're just lacking some oxygen, but in a heart attack, our tissues actually die, our cardiac muscle actually begins to deteriorate, and that's when it becomes a heart attack. Obviously, this is very severe, and again, coronary artery disease is a common cause. So, bypass surgery is something we see a lot with heart attacks and coronary artery disease. And what happens in bypass surgery, and it is pretty gruesome, is a surgeon goes in and will actually crack open the rib cage of the patient, harvest an artery from another part of the body, and, as the name suggests, actually bypass the whole blockage. So this is kind of a deceiving picture. When we get these buildup of this accumulation of plaque, it's not actually in the lumen, it's in the intima, the layer right outside. So we get an accumulation in the instance of soft atherosclerosis of foam cells, but we can also have foam atherosclerosis, which would be a slightly different mechanism, hard plaque. And when this is too severe to do something like a stent or an angioplasty, we actually just go over. So we take that artery, crack open the rib cage, take the heart, and go over. So now the blood flow, rather than having to try and push through here or try and vasodilate or open up that region, can just flow around. So you can have a single, a double, a triple, even a quadruple bypass surgery. Obviously, the greater blockages you have, the greater severity your surgery is. And so this is kind of the background on our patient. This is what they have going on. And so they've been given two medications. They've been given a diuretic and a vasodilator. And we kind of want to go over some of the patient education we would give this person. So let's start with the diuretic. The diuretic is also commonly called a water pill. And the reason it's called this is because the kidneys store less water and sodium. Why is this significant? So when our kidneys are storing more water and sodium, we have increased blood pressure, because where we have a high concentration of a solute, we're going to have high concentrations of water, which will increase our blood pressure. So in the instance of someone who has just had a heart attack, we're wanting to lower blood pressure. And that's exactly what they do. So we pee more, we urinate more, which gets rid of water and lowers blood pressure. Why do we want lowered blood pressure, especially after something like a heart attack and a cardiac bypass surgery? The short answer is it makes it easier for the heart to work. Why though? So there's something called Fick's equation, which is a measure of cardiac output. So Q equals HR times stroke volume. Stroke volume has three main factors, which is going to be preload, contractility, and afterload. And when we have increased blood pressure, when we have more blood at a higher pressure in our arterial system, it presses more on the aorta. So it's harder for blood to exit the heart because we have so much pressure coming in here. And the heart has to work too hard. We do not want that to happen, especially after someone's heart has gone through so much trauma and we have this going on and we're trying to heal and recover. So what we do is decrease our blood pressure, therefore putting less pressure right here so the blood can easier exit, making it happy. So with our diuretic, And with this patient in general, they're going to have to go through some form of cardiac rehabilitation to strengthen their heart, because the heart is a muscle. And so how is this going to affect exercise? We're going to increase. Which is a good thing. That means it takes less work for our heart to work at the same level. One thing you may see that can interfere with exercise is increased urination. This has less to do with actual exercise tolerance and is more just an annoying side effect. Someone can, of course, still exercise if they have to go to the bathroom a lot. Just do keep in mind, especially when you're educating this patient, that they will have to pee super frequently. And that may time kind of when they want to take this medication, especially if they have a longer drive to the facility, just something to be mindful of. So not anything to do with cardiac function. But may be annoying, honestly. I mean, for lack of a better word. Okay, so the second drug we want to talk about then is our vasodilator. This drug is what it suggests. It dilates your blood vessels. Why were we prescribed this? So in a heart attack, your heart, is not receiving sufficient oxygen. Why? This right here. So whether it's soft atherosclerosis or hard atherosclerosis, we're having a blockage. And so we almost get this pseudo-constriction where just in a specific area where we are not getting sufficient blood flow. So one of the things we want to do is ensure that we don't have this happen again. And that's why with things like a stent or an angioplasty, we try and vasodilate this area. In a bypass, we're going around it, but we still want to ensure that we are having as open a circuit as possible for blood to flow. And again, that's what actually causes the death of, the necrosis of cardiac tissue, is we're not getting enough oxygen, and our tissue needs oxygen to survive, especially our muscle tissue to work. So important to note, heart is a muscle and therefore needs blood, oxygen, and nutrients, which is something that's a really important theme here. Okay, so we have constriction, we have a blockage. We want to open up the blood vessels. So we take a vasodilator. This is good for the short term, obviously, because we are able to get more blood through, so increased blood to heart and muscles, actually. Long term, though, we may actually begin to see decreased exercise tolerance. Why? We're going to decrease preload. So we talked about it briefly over here with our Fick's equation, where Q equals HR times stroke volume. And then again, we have preload, contractility, and afterload. But what's going to happen is our preload is going to decrease. But one of the things that controls our preload is something called venous return. And our venous return is how much blood is returning from systemic circulation to our heart. And therefore, the more blood we have returning, the more we can eject, we can increase cardiac output, right? Venous return is affected by venous tone and venous or blood volume. So blood volume is pretty intuitive. If we have an increased amount of blood, we're going to get more returning. Tone, meaning the greater rigidity, the more structure. And we can explain this using the example of a water hose, actually. So if you think of a water hose, let's think about manipulating the diameter. Because our faucet, let's say we're not manipulating how much water is coming out. So it's the same amount of water, and we decrease the diameter of our hose. So this is our new diameter. Same amount of water coming through. think of it this way. You're creating a high pressure system, and so that blood is going to rapidly go out the water hose. And that's kind of the same idea here. When we have that increased venous tone, blood is rapidly shooting back into the heart. And the faster we can do that, the more blood we're getting. So then again, we're increasing our cardiac output. That makes sense, right? But with our vasodilators, what we're actually doing is kind of the opposite mechanism. We are increasing this diameter so that the same amount of blood is coming through, but now it's going so much slower because this is our diameter. And it's the same idea. So with our vasodilators, what we're actually doing is decreasing venous tone. And you can think of it like muscle tone. The more toned, quote unquote, someone is, we think of them as having less body fat because their body is tight together, like a tight diameter. Whereas if they're less toned, maybe they have a little more flab to them, increased surface area. And so that increased diameter is going to decrease the speed at which we can get blood returning to the heart and therefore decrease our preload. Overall, decreasing our stroke volume and therefore cardiac output. Obviously, immediately though, and it is called, worth mentioning, this is an emergency vasodilator. So yes, we are decreasing our exercise tolerance over time, but we are more concerned acutely about our patient's survival. When they have this going on, we are not concerned about how they can run a marathon, how they can even walk on a track. We are concerned about them surviving. So that's why it's prescribed, even though it decreases exercise tolerance, because it's honestly, it's not our concern at that moment. However, over time, it does become a concern, but it just can't be our priority, but it does decrease exercise tolerance. So that's just something to be mindful of when prescribing exercise. This person may not be able to be functioning as they normally would because of this. With both of these drugs, with the diuretic and the vasodilator, and understanding how they affect exercise tolerance and cardiac function, it's really important to understand this formula here, and we hit on this a lot with the various factors. We talked about mainly how these two drugs affect cardiac output. Different drugs affect things differently. For example, say a sodium channel blocker is going to impact your contractility because you're getting decreased depolarizations, which would decrease exercise tolerance. So different drugs affect things differently. I hope this gave you some insight into a little bit on these conditions and what may cause some of them, some of the medical treatments and interventions, and how they affect cardiac output. Thank you for watching.